Well, hello there, everyone. I'm Dr. Leslie Kernisan, board certified geriatrician and the founder of the website betterhealthwhileaging.net. And this is the Better Health While Aging video podcast, where we discuss common health problems that affect people over age 60 and the best ways to prevent and manage those problems. We also often address common concerns and dilemmas that come up with aging parents and other older loved ones, like what to do if you're worried about falls or safety or memory, or even the quality of an older person's healthcare. In today's episode, I've invited a special guest expert to talk about a topic that is really important in my line of work, which is what to know about urinary tract infections, commonly abbreviated as UTIs, and urine bacteria in aging adults. As you may know, UTIs are very common in older adults. They're actually the most common infectious illness in the over age 65 age group, and they're a fairly common cause of hospitalization. However, in geriatrics, we also know that UTIs are often incorrectly diagnosed in older adults because many people, including many doctors, don't realize that having a positive urine culture is not the same as having a clinical UTI that requires antibiotic treatment. If you're feeling a little confused, do not worry. I have a fabulous guest expert here with me today to explain UTIs and aging to us. My guest is Dr. Chrissy Kistler. She is a practicing board-certified geriatrician and a clinical researcher who has been studying UTIs and UTI treatment in nursing homes and in other settings relevant to older adults. She is currently an associate professor of medicine at the University of Pittsburgh, and I'm just really thrilled to have her here because she has been one of my go-to experts for UTI questions for the past several years, and I just know she's going to do a great job breaking this down for us. So, Dr. Chrissy, welcome, and thank you so much for being here today.
Thank you, Dr. Leslie. It is absolutely my pleasure. I'm very excited to talk about this subject.
Okay, so since there is so much actually involved in this subject, Dr. Chrissy and I are going to be breaking this down into a two-part series. So in this episode, we are going to cover the basics of UTIs in older adults. And then in part two, we'll be talking about UTIs in what we geriatricians often refer to as vulnerable groups. And that would be people who have Alzheimer's or dementia, another form of dementia, and or older adults who are in nursing homes. So Dr. Chrissy, why don't we start off right now with part one, which is UTIs in older adults. So let's just start with the basics. What does it mean to have a urinary tract infection? What are common symptoms? How bad can they get?
Yeah, so a urinary tract infection is in this case, bacterial infection. And I think, in your introduction, which was wonderful, UTIs are the most common bacterial infection. I think we all know with COVID and other types of viral illnesses that there are other infections that are also incredibly common and probably more common than UTIs. But UTIs in a woman's lifetime, probably 40 to 50% of women will have a UTI. And in any given year among older women, 1 out of 10 may have a UTI, if not higher. So it is very common. It's just there are other types of infections that can be common. And so it is an infection of bacteria in the urinary tract. And I think the important thing to think about there is that is sort of comes from the urethra, where the urine comes out of the body, and then up in a man through the penis or inside the woman's body into the bladder. And then that can go up through the ureters into the kidneys, which sort of sit in your back. If it is in the bladder, we call that a cystitis or a bladder infection. Any infection that is able to spread above the level of the bladder is a more involved infection, an infection in the kidneys, and can actually lead to sepsis, which is a whole body infection where the bacteria can get sort of loose and out of where it's supposed to be. And that can lead to hospitalizations, intensive care unit, and even death. So you can die from a urinary tract infection. That is absolutely true, though it is very uncommon to die from a urinary tract infection. So it is a bacterial, and there are different types of bacteria, right? So the question is, well, what type of urinary tract infection? We have normal bacteria on our skin that you can get that sort of staph infection in the bladder. That is less common than the normal type of bacterial bacteria that you get in your bladder, which is usually from the bowels, right? So unfortunately, our bowels and our bladder live right there. And that bacteria,
Especially in women, right?
especially in women, yes. And so, unfortunately, that bacteria can kind of be there, especially as women. We get sort of lack of estrogen. We may have more arthritis. Our bodies change, and our positioning can make it harder for us to have good hygiene. Wipe. We're all taught to wipe from front to back, but that can be more challenging as we get older, and that can allow bacteria to kind of live there. And that can then it's got not a lot of real estate to cover to then eke its way up and into your bladder and cause an infection.
Yeah. And so I guess to kind of like summarize, a urinary tract infection is a bacterial infection where you get kind of more bacteria than usual somewhere in the urinary tract. If it's just in the bladder, that is cystitis. And I think most of what we often refer to as a clinical UTI is actually cystitis, mostly focused in the bladder. But we do have these tubes that go up from the bladder into the two kidneys, the ureters. And I know for a moment I was like, yes, okay. The ureters, and a urinary tract infection can spread up to the kidneys. That tends to be more severe. That can be called pyelonephritis. And if the bacteria that is going on in the urinary tract gets even more significant and gets into the bloodstream, that can cause sepsis, a life-threatening infection that can, potentially even cause death, right?
Yes, and I should add, if you don't mind, that the presence of bacteria alone in your bladder is not a urinary tract infection, right?
Right. A very, very important point. So I want to come to that in a
Okay.
moment.
Sure.
But I think it's important to bring up because I feel like when I was younger, and maybe we were even I'm trying to remember when we were in medical school, but there was this idea that urine is sterile, that there is no bacteria in there. And we're actually discovering now that, first of all, it's not true. We have a microbiome of regular bacteria in there. And it's also even possible for people to become colonized and have a little bit more than usual, but not have a true infection. We are going to talk about that in a moment. But coming back to the clinical UTI, what are common symptoms? What are the sort of symptoms that might lead a person or a family caregiver to think, oh, this could be a UTI? What is it like to have a clinical UTI?
Right. So you do need symptoms. So let's just say that. So you need the presence of bacteria. If there's no bacteria and you're still having pain when you pee, it's due to something that isn't a bacteria. And there are lots of things that can cause pain when you pee that aren't bacteria. As an example, yeast. We get a yeast infection. Women do that sort of thing. That can cause pain when you pee. Even bacterial vaginosis, sexually transmitted diseases. There are lots of things that can cause pain when you pee that don't have the presence of bacteria, not a UTI. So you do have to have the presence of bacteria and then signs and symptoms in the urinary tract. Those include pain when you pee, having to pee more often than normal. Like, I feel like I have to go every 15 minutes. Like, I have to go, but when I pee, there's nothing there. Incontinence, like I can't hold my urine. I just like wet myself. That's not my normal. Normally,
And usually I do hold it. And usually you're having more trouble than usual.
we all might have issues because if we've had babies, you sneeze, you cough, you leak a little. This is not that. This is like, yes, normally I can hold it, and then suddenly I wet myself, and I never do that. So we talked about frequency, urgency, like I have to go. Like it's that, normally you can ignore your bladder a little bit, right? You could say like, oh yeah, I'm going to have to pee in the next 30 minutes. Well, there's also when you have a urinary tract, the bladder just gets really irritable. And so it's really like, I don't have to pee. And then suddenly it's like, oh my golly gosh, I have to pee right now. I have to get right there. And if I don't, I am going to wet myself. So frequency, urgency, incontinence, pain when you pee, pain sort of right there where your bladder sits.
Kind of in the lower belly.
Yeah, like if, maybe you've worn your pants a little too tight at times, you're like, "Oh gosh,"
Uh-huh.
that's where it is. Signs of an upper infection in your kidneys, that pyelonephritis can be that pain in your back.
Or kind of like the middle low back,
Right.
under the rib,
Under the ribs,
lower ribs, right?
Yeah.
Just
So people can know that's sort of where the kidneys live in your body.
Mhm.
And then obviously, if you're having fevers or chills, that's again a sign of a whole body infection, which can be more serious. Blood in the urine, if it's frank blood, it is actually probably more likely something else. Do you have a kidney stone? God forbid, do you have a bladder cancer? Or if you're on, something like that. So, frank blood is probably not. A little bit of blood might well be, but not usually frank blood. And then there are other things where people are like, gosh, the urine smells funny, or the urine doesn't look normal. And it's like, well, you eat asparagus and your urine smells funny. There are lots of, you become dehydrated, right? Maybe you're feeling crummy, and then suddenly your urine smells really concentrated, and it might even burn a little because uric acid is burning. And if you can't wipe well and a little urine stays down there, you can get some, irritation. And I've seen some incredibly distressing, like contact dermatitis from urine, where people maybe have some incontinence at baseline, and that can really irritate things. But that, if it's just my urine is a little stinkier than normal, or it's, the color's a little not right, that it's cloudy, not that's dark. Right. Those might be signs of something, that is, you're dehydrated, but less just they're not considered to be a sign of a urinary tract infection.
Yeah. And I think it was even actually like studied at some point that these visual signs that people were often using, especially nursing homes, to sort of presume there's a UTI, actually did not correspond to the presence of them. So to come back to, the symptoms of a UTI, you said it's pain when you pee, pain or burning. It's having to go much more often than usual, especially if it feels very urgent. It's incontinence or more difficulty with continence than usual, pain in your lower belly, maybe blood in the urine, or even pain in your back, the kind of like lower mid back where the kidneys are. Those would be some symptoms of urinary tract infection. Or if it's really spread and gone bad, fever.
Yeah.
Along with those. Okay, so how do UTIs become different? Well, actually, before that, how do UTIs become different as we get older?
Yeah. Um, our whole body changes, so it should be of no surprise that your bladder might be part of your body and change a little as well. And we know that that loss of estrogen, which again, in theory, is a whole other organ, but it also affects where the bladder is sitting and how the bladder sits, and sort of the defenses and the skin in that area, which can change the barriers to that bacteria getting up there. And so we find that, in fact, as women age, they do develop more just general incontinence, and the bladder doesn't sort of empty in the same kind of way that it might have when they were younger. And so the colonization it becomes much more prevalent. Like you said, maybe it is true that when you're 18, your bladder is relatively sterile. But as we age and we seem to develop sort of an underlying colonization in a lot of our bladder, that can predispose you to have more urinary tract infections. But we have found that if you treat that bacteria when there is no actual infection present, all you're doing is selecting for really resistant and sort of, I call them nastier bugs, so that when they flip over and they really start to overgrow your bladder and cause you to have an actual infection, it can be much worse, and you can need a lot more serious antibiotics to treat it.
Yeah.
There's been randomized trials of trying to treat what we would call asymptomatic bacteriuria, and it doesn't show that it actually reduces your risk of any serious UTI.
Okay. So I think that's like a really important point that a lot of people don't realize is that, first of all, lots of older people have at least a little bit of bacteria in their urine or urinary tract. And that as we get older, it becomes increasingly more likely that we will be colonized with bacteria that is called asymptomatic bacteriuria. And so, how do we know that somebody has asymptomatic bacteriuria? How common is it, this sort of colonized bladder,
So
which is not a UTI, clinical infection, because they are not having the symptoms that we were just describing.
right.
Right.
It becomes more prevalent as we age because, again, our defenses to keeping bacteria at bay are diminished. And so if you look at 60 compared to 70, compared to 80, you will see increasing rates. If you look at nursing home patients who, again, maybe they're not able to wipe in the same sort of way, maybe they are less immunocompetent, so their immune systems aren't as robust, the rates of asymptomatic bacteriuria. So if you walked into any given nursing home and you tested every woman, you said, let's clean you up, let's get you to pee in a cup, and let's see if we can grow a good chunk of bacteria. What you'll find is up to 70% of women will grow bacteria in their urine.
Aye.
And that's on any given Sunday. And we also find it's important when we talk about the presence of bacteria, we are also looking at the urine. So you'll see this happens a good bit. You go into the emergency department because you're not feeling well, you think something's going on. Maybe it's not a UTI. Let's just suppose that. They look in your bladder and they may do a urine analysis and they say, oh gosh, look, it's got nitrites, it's got leukesterase, you've got a UTI. You can't diagnose a UTI from the urine analysis. Like that is just not possible. So when they tell you that, what they're suggesting is that your urine looks like it might, but until it grows something, we don't know. Because it may just grow a little bit of bacteria, and that leads you down the wrong path if somebody says you have a UTI and they're not treating you for your dehydration or they're not treating you for your constipation. I've had patients who had these massive poop balls that actually pushed on the bladder, caused retention. Their bladder can't empty. It looks like they've got a UTI, but nobody's treating the fact that they've gotten their constipation because somebody started them on a little oxycodone or Percocet, or somebody increased their blood pressure medicines, which will highly constipate you. So I worry sometimes that we get narrowed in on the bladder when we need to have a bigger perspective.
Absolutely. Okay. So that's really, the thing that we grapple with in geriatrics, right? Is that we always know that there's this challenge, which is that, yes, UTIs are common in older adults, but it's also very common to have this colonized bladder, this asymptomatic bacteriuria, and that distinguishing between the two might be a challenge. And that it's very easy for either patients and families or the doctors who are treating them to kind of zero in on, oh, look, something is not 100% normal with the urine. This is the cause of the problem. And it may or may not be. So maybe we can at this point talk about how should UTIs be diagnosed in older adults? And maybe we can talk about the role of urine testing and just how you would evaluate an older person for a UTI.
Right. So obviously, if you are immunosuppressed or you have some abnormal bladder thing, like you're a man and you've had your prostate removed and maybe things don't work quite normal, you may be more at risk. So first off, I just want to say, let's talk about kind of our most common scenario, which is our older woman. So first I want to know, okay, are you having localizing signs and symptoms, right? If it's like, I have pain when I pee, okay, I am going to take your urine first because I want to send it for culture. A culture would be important here, not to decide do I treat or not treat, but it will help me decide if what I chose to treat you with was the right thing. We know there are high rates of resistance now, right? Lots of bacteria have been exposed to antibiotics, and therefore I don't know. There's no way to know necessarily that the antibiotics I choose, even though it's a first line antibiotic, let's say, maybe this bacteria is resistant. So I first want to know, do you have localizing signs and symptoms? I want to send that urine culture, and then I want to treat you. And I'm not going to wait until the culture comes back. I'm going to treat you right there. Let's say that culture does come back in 3 days and it's negative. I want to stop your treatment. Okay. I want to say, okay, that I was wrong. We thought it was this, but it obviously can't be because your culture is negative. Let's make sure we're, doing that thorough workup. And honestly, I would hope I would have done some of that workup to begin with. Like, I look down there and I see what's going on. And so we check for other things that might be happening. So really for me, it's the signs and symptoms of a UTI and I treat.
Okay. So it sounds like to diagnose the urinary tract infection, you really want to ask about those symptoms that we talked about before. Is there pain, frequency, incontinence, low belly pain,
Urgency.
back pain, urgency? You want to send a urine culture. You probably would still do a urine dipstick, right?
You probably would.
Can we talk a little bit about what shows up on that?
Sure. So if it's negative, when I dip, you have your urine, you put this thing in it, and then you kind of look at it. If it comes back and it says there's no bacteria, you can look for white cells or bacteria or for nitrates or leukosterase. If all those come back as negative, the chances are that it's a UTI are pretty slim, to be honest. If it's positive, however, I don't really know what to do with that. There's some tests where it helps me rule out the presence of a UTI, but doesn't necessarily slam dunk, yes, the presence of a UTI. And so I may still do a urinalysis. If it's grossly negative, I may actually say, hey, it doesn't look like it's a UTI. I'm happy to
Think about other things.
yeah, let's hydrate you. Maybe it's that you're constipated. Maybe we need to hydrate you. Maybe we need to do more barrier cream down there and you've got a little urethritis, but it's because of irritants. It's not because of a bacteria. And so I might go that route. That's an absolute definite yes. Or I might say, okay, let's treat you. And we're going to do a timeout is what we call them. We're going to do like a 72-hour, timeout. Culture comes back, that gives us time to reassess things. And so I've had patients who've been like, okay, no, I'm okay. I don't want the antibiotic right now. I'm going to push fluids. I'm going to, try to make sure that my bowels are regular. I'm going to do time toileting. So I'm going to try to empty my bladder on a regular basis. And so maybe just by doing those things, whatever those symptoms are, it'll go away. And then we'll reassess after 72 hours when the culture comes back. Okay, yeah, it doesn't really look like it grew a lot. Sometimes they grow what's called mixed genital flora, which isn't like any one thing. It's just kind of like bacteria that we have down there. So again, it's a sign that this really isn't likely to be a UTI. And so then you can say, okay, great. How are your symptoms? My symptoms are much better. I'm doing wonderful. I guess I didn't need the antibiotic anyways. And you go from there.
Okay. All right. So let's now talk about the scenario that I think is much more common, which is that an older woman says, I'm not feeling so good. She's actually not asked a lot of questions about her specific symptoms. They just maybe dip her urine. It has, some abnormalities. They get a urine culture. It's positive. They say, you have a UTI. Is that a correct way to diagnose a UTI?
I feel there might be a little bit of ageism sometimes going on because if I, or a 20-year-old woman came in and said, I've got the blahs and I just don't feel good. People are going to be like, oh, how's your mood? Or how's your thyroid? Or how is, whatever's going on in your life? They're not going to be like, oh, she has a UTI, right? No one's ever going to do that to her. But yet a 70-year-old woman walks in and she's like, yeah, I just don't feel well and I just don't whatever. And okay, here's your antibiotic and go on your way. Right. So I just worry that we pigeonhole women into this bucket that says, any vague, nondescript complaint. Oh, it's just your bladder, sweetheart. Here's an antibiotic. As opposed to maybe she's depressed. Maybe she has arthritis. Maybe she has lots of other things that are not, in fact, a bladder infection. So I would say no, that is not the way I go about diagnosing UTI.
Right. And also because, as you said, if her symptoms are very nonspecific, but she has a positive urine culture, we don't know whether she is colonized. She might be colonized.
Correct. Correct.
And so tell us a little, I want to talk about a little bit more about why we don't treat colonized bladders. But first, since you had mentioned we're talking about older women, can we talk briefly anything to keep in mind when it comes to older men and UTIs? Let's say they haven't had the prostate completely out, but it is true that many older men have an enlarged prostate and may chronically have some dribbling or a little bit of difficulty totally emptying their bladder. Are they at higher risk for UTIs, and are there any special considerations in diagnosing UTIs in them?
I think I think you're right. I think men have higher rates of sort of, again, like in a woman, we want her to empty her bladder in an organized fashion, and we know that as women age that can be more difficult. In men it's the same way, different reasons, but men also have a hard time emptying their bladder. That can absolutely set you up for a urinary tract infection, and I don't want to discount that. So again, if he says I have pain when I pee, or I do dribble fine, but now I'm like wetting myself, all of the same signs and symptoms that apply to women apply to men, and we should listen to them. I do think you have to be cautious because sometimes it's because their heart docs that started them on, furosemide or,
Yeah, a diuretic, a water pill.
and suddenly they are wetting themselves because we're kind of causing them to do that. There's an iatrogenic, component to that. And so, yes, I also think it's important to recognize that, for example, if a person has a stone, they have a little nidus, a colonization of bacteria that can sort of flare up and cause them to have pretty significant infections. So that's sort of another type of thing you need to be mindful of. And then if men do have prostate issues and have had issues around prostate cancer treatment, sometimes men develop connections between their bowels and bladder that can also cause pretty serious life-threatening infections as well. So I take urinary tract infections in men very seriously, but I also do think that there are lots of things in men that we do to them that can also cause them to have urinary symptoms. So it's still important to get that sample and send it for culture because you really want to make sure, yes, this is bacteria.
Yeah.
So
But men also can be colonized, right?
absolutely. No, if you have a person with a suprapubic catheter, which some men may because they've had issues with their prostate, or somebody who has to straight cath fairly frequently, 100% of those people after a month are going to have bacteria that has made its way into their bladder.
Right. And even men who don't have that, a certain number of older men are also colonized. Right.
Absolutely. Uh-huh.
So it's still the sort of same rule, which is just because there is a positive urine culture does not mean it's a clinically significant UTI. They still need to be having some symptoms that are specific
That is
to the urinary tract. So let's now talk about the thing that I want to talk about two situations that come up I think a lot. So one is when people tell me they've been having these symptoms, whatever they are, for weeks and weeks, and they think it's a UTI. What is your approach to that?
Yeah, that is a hard one, right? That's not easy. I would first take a look. Maybe there is some degree of bladder dysfunction, right? Is this that they have an overactive bladder, or are they having retention, or are they having some other kind of urinary bladder issue that is leading to those symptoms? Now, those things, so for example, retention can also lead to an infection, right? So we can never discount that, oh yes, it's been going on for weeks. Well, it may hit a tipping point where now it is an actual infection. So
Mhm.
just it's this balance
Right.
between the chronicity of the symptoms and what we see. But I would say that we really we need to work that up. Those are real symptoms. We just need to make
Mhm.
sure that we don't sort of pigeonhole them into the this is a UTI bucket, because again, that delays us from getting, vaginal estrogens in place. It delays us from trying, some of these bladder medications to help calm the bladder down,
Mhm.
right? That doesn't help anyone to tell
Mhm.
a person they have a UTI when in fact they don't, right? It
Yeah,
just
yeah.
delays
Right.
diagnosis of the real
Yeah.
thing.
I generally feel like if it's been weeks of the same symptoms, I mean, if it was a UTI would either have cleared itself by then or turned into more.
Correct.
And that there is something else going on, and yes, you could have weeks of that symptom and then it turns into a UTI, in which case there should be some kind of new symptom or something.
Exactly.
Generally.
Exactly.
Right. So when people say it's been weeks or months, and I think, well, we might have to think outside the UTI box.
Right. And oftentimes I start thinking, okay, do they need to see urogyn, or do they need urodynamic studies? Do I need to see how well their bladder's working? I mean,
Well, something's going on. We are in agreement, right? It's just not necessarily an antibiotic prescription that is going to be the fix. Yes.
Exactly.
Okay.
Exactly.
All right. Okay. So the other situation that I wanted to bring up that comes up is the older person who comes in and has become confused. And, could that be a UTI?
So, they've looked at large studies where they've tried to figure out, is there an association? I mean, I was taught in medical school that if an older person fell, that you needed to look in their bladder.
Oh, yeah, that they might have a UTI. And that's why they fell.
That's why they fell.
Right.
And that's a lie. So the truth is that the number of things that cause people to fall are almost infinite, right? And the number of things that can confuse people is also near infinite. And so, again, we have this premature closure of our thought process. We close off our diagnostic workup and we just pin it on the path of least resistance. And so then again, you're treating them with things that aren't treating the underlying cause of it. And that, and you might be able to get ahead of it if you actually look for what was really going on. So is it that, again, they're having a hard time, they got a GI bug and so they're dehydrated, right? Or that they've got COVID and they're having issues, or that their blood pressure medicines have been aggressively titrated and now they're hypotensive all the time, right? Is something going on in their labs? Is something going on in their oxygen status? Again, the number of things. Did they take a Tylenol PM that night, right? The number of things that cause a person to wake up and feel fuzzy in the morning is almost infinite, right? I mean, heck, I don't sleep well, or my neck hurts. I feel fuzzy in the morning, right? So can we just make sure that we don't pin the tail on the nearest donkey at hand, that we actually find the culprit that is truly responsible?
So it sounds like in general, you would not consider just new confusion on its own to be a sign of a UTI. Certainly, we want to think outside of that box, and especially if the person otherwise kind of has normal vital signs and doesn't have a fever. I mean, sure, we could check their urine or culture it, but it might come back positive because they're colonized.
Exactly.
Right?
Yes.
So we want to be very cautious about attributing that to a UTI unless there are, again, some of those symptoms that are very specific to the bladder and the urinary tract, right?
Absolutely.
Okay. So, and then coming back to that colonized bladder, asymptomatic bacteriuria. So I have found that people often want it treated. It's a positive urine culture, so it should be treated. Can you talk a little bit again about what the research has taught us about trying to treat a colonized bladder with antibiotics?
Yeah. Unfortunately, it would be great if you treated it and then the bacteria was gone and it would never come back. The issue is the thing that got it colonized in the first place usually is not going to go away. Again, you should push fluids, flush the bladder, time toileting, get rid of your constipation. All of those things can really help reduce your risk of having both UTIs and colonization. However, if you treat it, all you're doing is now selecting for agents for bacteria to grow that are resistant to whatever you've just treated it with. We know that, for example, pneumonia, right? Levaquin can be very good for that. It's a fluoroquinolone. If you give somebody ciprofloxacin for their bladder, you have, for all intents and purposes, removed that fluoroquinolones to treat their pneumonias with oral antibiotics. You might be able to get away with Augmentin or some of the other, third generation cephalosporins, but you're really limiting your armamentarium. And every time you are exposed to an antibiotic, you are creating resistance for you. So I know some people are like, gosh, what do I care about like global resistance patterns? Well, it affects you as a person. We know that if we can keep your exposure to antibiotics low, that we will reduce the resistant bacteria on you so that when we need that antibiotic, we can use it. And
Mhm.
I kind of talk about it like, you don't just leave the lights on all the time, right? You turn the lights on when you need it, because if you left them on all the time when you really do need the lights on, you may turn on the switch and they're out, the bulb's gone out. And so then I've had patients who have been just inundated with antibiotics for years, to the point where if they ever get a true urinary tract infection, they have to be hospitalized for IV antibiotics.
Mhm.
We don't have oral agents to treat them at home.
Right. Right. Okay. So, and there's also, I mean, first of all, we're learning more and more that when people take antibiotics, it affects their gut microbiome and potentially has some consequences there. And then there's always the possibility of some kind of side effect, adverse reaction to a given antibiotic. Sometimes with fluoroquinolones, people can get tendon problems. People can get like upset stomachs. People can even sometimes get a more serious intestinal infection from antibiotics. And so I think there's been increasing awareness among health providers that you want to be judicious with antibiotics.
Yeah, I mean, we never saw C. diff, right, when I was in med school, and then we've had just catastrophic rates of it. We found that as stewardship has become kind of a motto, and more of people are champions of antibiotic stewardship, those rates have fallen. But we never saw people die of C. diff 20, 30 years ago, and then we
Yeah.
started
And
to.
C. diff is an overgrowth of a very aggressive bacteria in the intestine that tends to come on after people have had a lot of antibiotic treatment, right?
Exactly. Yeah,
Yeah.
absolutely.
Okay.
So, yeah, we are seeing side effects, not just, people can have allergic reactions. You can also have heart problems, heart conditions from your antibiotics. There's all kinds of things. They are not this benign, panacea that makes all things better for people.
Right, right. Okay. So coming back to UTIs and their treatments. So we know in geriatrics that UTIs are often incorrectly diagnosed, sort of prematurely. Whatever problem an older person is having is attributed to a UTI that should be treated with antibiotics. That being said, some people do have real UTIs. They have more bacteria than usual growing in their bladder, and they are having symptoms localized to the bladder, like pain when they urinate, or increased frequency, or urgency, or that low belly pain, or maybe even pain around the kidneys. And we do treat them with antibiotics. We want to take a look at culture results to make sure the antibiotic they were given is something that the bacteria is actually susceptible to. And most of those UTIs that happen in the outpatient setting can be treated very successfully with oral antibiotics, especially if the person hasn't been taking tons of antibiotics before then for various reasons. And occasionally people are sicker and do get hospitalized, might be treated with IV antibiotics. Now, what I wanted to ask you about is the situation of recurrent UTIs, because I do get asked about this. The older person who keeps getting a UTI over and over again. Tell me a little bit about how you think about that situation and what you recommend.
Yeah. So that's a sticky thing, because there are people who get recurrent serious bladder infections. For those people, I want to make sure there's not an abnormality there. So, right, there's not a stone in their bladder that is sort of setting them up for failure. I want to make sure that the bladder is draining properly, and so sending them there for urodynamic studies. I start to think about, okay, what can we get really aggressive in prevention? So estrogen for the paravaginal area, that will help with the urethra as well. I also do think, the evidence is not really there. You'll hear cranberry be touted as an intervention. It doesn't look that like the data is very strong in that regard. It's not something I recommend. The one that I have become more impressed with is methenamine,
Mhm.
which actually acidifies the urine. There is a small trial that shows some benefit. It's about equivalent to putting people on a low dose of antibiotic consistently. So it's sort of like an antibiotic without being an antibiotic. It really creates that acidic environment. You do have to take it under the advice of a physician or a provider because it's processed in the kidneys. So if you have any too much kidney dysfunction, you shouldn't be on it. But I found that it really has helped reduce people's rates. And then again, is this a UTI? So that for every time they say I have symptoms, that culture comes back positive? Or is it that I had symptoms and sometimes the cultures are positive and sometimes they're not because maybe I need to work on controlling their, irritable bladder, their overactive bladder, their retention, or some other mixed component of that.
Yeah. Yeah. And also, which was the symptom that has been concerning because I've certainly had a number of patients in their 90s where I was told they were having recurrent UTIs. And what they were having was recurrent days when they were very tired or more confused than usual, a positive urine culture
Right.
being treated. And my question as a geriatrician was maybe this is a colonized bladder
Right.
that keeps coming back. So that is the other thing that I think we think about as geriatricians is what was the symptom that kept triggering the urine culture? And maybe it wasn't what we would consider true UTI symptoms.
Right. So that's 100% true. She wasn't feeling funny. She didn't finish her oatmeal. She must have a UTI. I would strongly discourage looking in a bladder. You don't want to know what's there because you don't want to treat what's there. You want to treat that person. And if she's not eating her oatmeal, well, is it because, again, she's constipated? Is it because she's dehydrated? Is it because she doesn't like oatmeal? And maybe you need to give her something she likes. Or do people just
Does she otherwise seem very sick? Or maybe she has a virus.
Right.
You let her rest for a day. How is she tomorrow?
Exactly.
Yeah.
I think tincture of time can be a great ally.
Yeah, with some of those patients, we've just stopped the treating UTI cycle, and they just found that if they let the older person rest a day or two, they came back to normal, and then it's just they're having days when they're tired.
Yeah.
Exactly. Which can happen, which can happen for some people, and so then we really talked about how to look to see, like, signs that the person was getting maybe dangerously sick, so maybe we can talk about that. What are red flags,
Yeah.
you know?
I think there's a difference between I can't wake her up,
Mhm.
and she took a longer nap today, or she took a nap today. I think those seem to be two different things. In the nursing home, we can monitor your vitals, and so if you start to have a fever, and I think it's important to recognize that as we age, our resting temperature does fall. So that whole 98.6 is probably not true for most of older people. It's
Right.
probably more closer to 97.5. And therefore, if they've got a temperature of a 99 or 99.5, that may be a legitimate fever in that person.
Right.
Yeah. So
Yeah.
I think, we can take their temperature. We need to interpret it based on what their baseline normally is. And so that's something you can measure even in your home. In the nursing home, we make sure that like their heart rate's not high or their blood pressure's not too low.
Which is something people can do at home too. Many people now have home blood pressure
Yeah.
machines, especially if they're being treated for high blood pressure.
I mean,
It was very common.
your watch will tell you what your pulse is doing these days.
Right, whether it's, like, very different than usual. Really quickly, have frequent UTIs been associated with any long-term health consequences?
That's an interesting question. I think if you are sick again and again and again, and it really is a bacterial infection, right? So if you have a stone that's causing you to be sick, then yes. But I think that if this is asymptomatic bacteria, the answer is no. People have asymptomatic bacteria and live with it for decades and are just fine. No, I think it's again that true question of is this an infection or not an infection?
Okay. And when people have asymptomatic bacteriuria, are they at higher risk for UTIs?
They are. I mean, you have bacteria there. It's kind of like our skin, right? Our skin has bacteria on it. Normally, it's not got an infection, it's not got an abscess or cellulitis or something like that. But because we do have bacteria there, there is an increased risk that we're going to get an infected wound if we have an infected wound.
Yeah.
So,
And I guess as we were saying, the colonized bladder often reflects an aging immune system, right? And that just puts you at risk for infections in general.
there was an interesting study that was done in Scandinavia where they actually they took, just like for C. diff, where they will give fecal transplants, they took a distillate that had sort of more benign bacteria and instilled it in a bladder, in these women's bladders who had recurrent UTIs, and their rates of symptoms fell. So,
Okay.
and in fact, we really want to preserve our natural microbiome, I think, as an older person, if we are at all able to. So, I
Mhm.
think good bacteria is good bacteria.
Okay. So maybe as we wrap up this episode on UTIs in older adults, what are some questions that older adults and families should ask their health providers when it comes to UTIs and positive urine cultures?
That is a great question. I might have to think about that for a sec.
Sure.
I would say that if you're having symptoms, you should be treated. And if you are not having symptoms and someone comes to you and says, "Hey, we think you have a UTI," you should say, "Why? Why do you think I have a UTI?"
Mm-hmm.
And I,
Okay.
I don't think a person's default should be everything is a UTI. I think we
Mm-hmm.
need to be a little more, we should push back on it so that you get the right diagnosis for you. And you're not falling into that trap of, oh, something's wrong with them, must be their bladder. So I would just say the questions would be, why, doc? Why do you think I have a UTI?
Mm-hmm. Yeah. Okay. So great. Well, I guess to recap, what we've covered today, urinary tract infections are very common in older adults, but are also commonly incorrectly diagnosed in older adults. So it's reasonable to diagnose them when an older adult is having symptoms of a clinical UTI. So those will be symptoms related to the urine and bladder, burning or pain when you pee, greater frequency, greater urgency, worse incontinence than usual, pain in the low belly, pain maybe in the back, maybe blood in the urine. Those are signs that are the clinical signs of a urinary tract infection, along with having more bacteria than usual in the bladder, which should show up with a urine dipstick that is positive, and it'll grow a urine culture. And if that's what the person has, then treating with antibiotics is reasonable. However, many older adults will have just vague symptoms, but they have a positive urine culture, and that could be a colonized bladder, asymptomatic bacteriuria, which is quite common in older adults and becomes increasingly common as people become older or frailer. So we always want to make sure that an older person who has a positive urine culture also has symptoms, right?
100%. And I would just say we want to treat you for as little period of time as we can. It used to be we'd treat for weeks, it was like 10 days and then it was 7 days. And now many times urinary tract infections, if they're just in the bladder, it can be 3 days, 5 days. It doesn't have to be a protracted period of time. And
Okay.
you don't look to see if it's gone. So
Mm,
you treat it, your symptoms go away, wonderful, and you're done. Don't go looking in the bladder again unless symptoms return.
okay. All right. And then, we talked a lot about asymptomatic bacteriuria. So, a positive urine culture in the absence of any other symptoms generally means a colonized bladder and does not require treatment. Multiple studies have been done and found that treatment did not reduce mortality, did not improve outcomes. What it does increase is your chance of having drug resistant bacteria when you actually do have a UTI or significant infection. And then, Dr. Chrissy, you were saying just for kind of like prevention, estrogen, vaginal estrogen can be very helpful, especially for women. Good hygiene, and methenamine.
Yeah, and hydration and keeping, your bowels regular so that you don't have a lot of constipation going on.
Okay. Those are all things to consider as well. And then for a very vague symptom like falls or a little new confusion, it's important to think more broadly and not just attribute it to the positive urine culture, which may well be a colonized bladder.
Correct.
Okay. All right. Well, Dr. Chrissy, thank you so much for, do you have any last favorite resources to share? You want us to post in the show notes?
Sure. I mean, I'll tell you, there are lots of really smart people that have done a lot of thinking around this. I think the CDC actually has several resources that are available. They're the big people who do infection. And so they're also interested in bladder infections as well. I like the Infectious Disease Society of America, but I think that's more for clinicians, less for maybe the general
Yes, but
public.
they actually have been recommending for years that clinicians stop treating asymptomatic bacteriuria.
They have, and so I think their guidelines are well developed, they are very thoughtful, I really like them also. There are other for long-term care guidelines, which I think we can talk about, in our
In
next.
part two.
Yes. So,
In-
I think in general, I like the AHRQ has some as well, the Agency for, Health, Research and Quality, and then the CDC. Those are my big ones that I like.
Okay. Well, Dr. Chrissy, thank you so much. This has been so informative. And thank you so much for taking us through this.
You're welcome.
And with that, thank you very much for watching. I'm going to wrap up this episode. And so if you found this episode helpful, if you're here on YouTube, please go ahead and subscribe. It does help more people find the channel. And if you're somebody who is trying to figure out how to help an aging parent, I have a special interest in supporting people like you. So I've created a variety of helping older parents resources and trainings. And I also have a book called When Your Aging Parent Needs Help. So if you would like to get more useful information on how to care for aging parents, including my free online trainings, please visit betterhealthwhileaging.net/helping-older-parents. Last but not least, if you've been listening to the audio version of the podcast, come and take a look at the video if you get a chance. You'll be able to see some of the key points displayed on the screen. So thank you once again, and I look forward to seeing you on a future episode of the Better Health While Aging video podcast.